Here's lesson E for 150, the next to the last lesson in the 150 course. In this one, we're going to talk about distributive shock. In the previous lessons, we've talked about obstructive shock, hypovolemic shock, cardiogenic shock, and now we're going to talk about distributive shock. We're going to define it, assess it, and talk about how to make interventions. Recall that in hypovolemic shock, the idea was to find that they are in shock due to that cause, stop the loss, replace the loss. In cardiogenic shock, it was a key to figure out that it was the pump that's the problem. Either the rate's too fast, the rate's too slow, the stroke volume is inadequate, or the afterload is too high, and figure out what the problem is in order to figure out what tool to use. Very similar in distributive shock. And so we're going to talk about these cases where SVR is a big problem. Abnormally large container size will cause you distributive shock. There's too much vasodilation. Could be one of several causes. Could be a neurogenic shock, could be a septic shock, could be an anaphylactic shock. So regardless of the cause, the problem is that the container size is too large, and the pump must now circulate more volume. The patient is actually relatively hypovolemic, in that they haven't lost any volume, but the container size now doesn't match up to the volume that's present, so they're relatively low. One cause is neurogenic shock. The neuro system, which we'll cover in the next lesson, but the neuro system is monitoring that blood pressure through the signals coming from baroreceptors in your carotids and in your aortic arch and other places. And the brain is monitoring that BP, and when it notices that the BP is dropping, it sends commands to the blood vessels to constrict and the adrenal glands to secrete some epinephrine. But the problem in neurogenic shock is those commands never get through. So the brain is making the right decisions. This is not a brain problem, it's a spinal cord problem. This is not the same thing as a traumatic brain injury or a stroke. The brain is functioning just fine, and it is sending out correct commands, but those commands are simply not getting through. The fix is usually to fill up the container because it's now too big. It shouldn't be this size, but it is. So we can fill it up or we can shrink it down. Well, filling it up is pretty straightforward. So, with cardiogenic shock, we said, don't just go to a fluid bolus to solve your problems. Hypovolemic shock, that's the way you go. And in most cases of distributive shock, particularly neurogenic shock, if you believe that this patient's spinal cord is disrupted, squeezed, pinched, or cut, whatever the cause, the signals are not getting through, they're not going to get through. Fixing that is not something we can do in the field, so we're just going to have to fill up the container to its new size so your patient's no longer relatively hypovolemic. And then we may be able to do some shrinking of the container size as well. Neuroshock assessment is a little different. Well, the results of your assessment, the signs and symptoms that you see, and the things that you notice in your physical exam yield you different things in neuroshock than in other shock. Usually the injury is at mid-thoracic, say T6 or higher. And so, it could also be that there's other injuries, so I'll come back to that in just a second. But usually this is a problem with a spinal cord injury in the mid to upper T-spine or higher in C-spine area. And those compensation signs, the cool, pale, clammy skin, are present above the injury where the innervation is still intact. But they're not present below the injury, the line on the patient. So, as an example, if a person has an injury in the T4, T5, T6 range, they may be cool, pale, and clammy above the nipple line and flushed, warm, and dry below. Same thing at T10. If the injury is a little bit lower at around T10, typically that line may occur around the belly button, around the umbilicus. And so they'll be cool, pale, and clammy on their face and shoulders and upper chest, but lower abdominal area and legs are going to be flushed, warm, and dry. You won't always get the tachycardia. In some cases, you may get an actual bradycardia in these people. So if someone says, what are the signs of shock? You typically say tachycardia and cool, pale, clammy skin. And so in neurogenic shock, that's not always the case. In many cases, it's the opposite. So if you're able to assess the ability to move extremities, that may give you a pretty good clue. A disruption in the ability for the spinal cord to carry signals will also usually result in a disruption in its ability to do motor function. So this is another reason why it's history and physical. It's not just history, it's not just physical, it's history and physical. Then I said a while ago that I was going to come back to something, so I need to come back to that. So if you have an injury that can cause disruption to the spinal cord in the upper T-spine, that's pretty significant impact to the thorax. So don't forget that injury could also have caused significant bleeding in the chest, maybe broke a rib, maybe be leading to tension pneumothorax. So you might have hypovolemic shock and neurogenic shock. You might have hypovolemic shock and obstructive shock along with neurogenic shock. You could have more than one thing. So if the injury is significant enough to disrupt the cord, don't forget that there could be other problems as well. Another cause of distributive shock could be sepsis. This is a massive systemic infection that has triggered the release of substances, and we don't really need to go into what all these things are. You can read about it if you want. It doesn't change the treatment of your patient, and so we try not to fill your head up with stuff that doesn't really matter to Mrs. Smith and how you take care of her. But just realize that this massive infection is causing the vasodilation. It's also causing some depressed cardiac pumping, and then there's some microvascular leakage as well. So septic shock is particularly evil in that it has a little bit of hypovolemia to it, a little bit of cardiogenic shock to it, but it's mostly distributive. And so if you have a massive systemic infection, the idea is to kill the bug causing the infection. And you do that with, big deal antibiotics, which we don't have in the field. In the meantime, in the field, we're going to fill up that container, and then we may need to also try to shrink it down with some alpha agonists, some vasoconstricting medications. Think norepinephrine. So the big deal here is recognize that they're septic, start filling up the containers, start moving them toward early use of antibiotics to try to get rid of the main problem. We're just doing temporizing measures by trying to fill up that container, and then you may end up with some pharmacological intervention here in terms of an alpha agonist, a big vasoconstrictor. Sepsis, the history of the present illness, is what really tips you off here. They're suspicious for a systemic infection. It could be a dental infection. It could be a urinary tract infection. It could be an upper respiratory infection. It could be an infection from a wound. It could be anything that can cause an infection. People that are in long-term care settings and relatively bedridden, and particularly those that have indwelling urinary catheters, end up with urinary tract infections quite frequently, and those are a major contributor to sepsis, as well as a pneumonia, some sort of upper respiratory thing, or lower respiratory infection, a respiratory infection. So you would think that if this is a massive infection, this patient would have a massive fever, and they may. They may be very, very febrile, or they may not. They may actually have a lower temp than normal. So don't go through life, key concept here, don't go through life thinking that if your patient doesn't have a fever, they can't be septic. That's just not true. And then your capnography will be a little lower than expected for that patient. And we can go into why that is, but just for now, just know that that is. And so that might be something where you would normally think 35 to 45 and your guy's running in the upper 20s, and he has a temp of 96.4 but it's the history of present illness that tips you off. There's a reason for them to have a systemic infection. Another cause of distributive shock, so we've talked about neurogenic briefly, we talked about sepsis briefly, would be anaphylactic shock. And this is a systemic, over-exaggerated, crazy, out-of-control response to an allergen. If you have an allergy to bee stings and you get stung by a bee, you release way too much histamine, not the normal amount that's released by people that don't have an allergy to that. Same with seafood or aspirin or penicillin or peanuts or whatever else a person might be allergic to. They have an exaggerated immune response, and the key for you to remember is that the immune response releases histamine. So an exaggerated immune response releases way too much histamine. Why do we care? Histamine is a vasodilator. So you end up with a very large amount of histamine causing the container to be excessively large. And the problem is that the reaction, the allergic reaction has caused that. And if we could interrupt that chain of reaction, again, there's several steps in it, and we don't care that you know all those specific steps. That's relatively trivial at this point. You might be able to read and understand the neurochemical, biological stuff that's going on. That's great. There's nothing wrong with that. But we need you to understand what's going on and understand how to deal with it. So you might think that if an exaggerated release of histamine is the problem, why not give an antihistamine like Benadryl? Well, that doesn't stop the reaction. You're just trying to treat the symptoms. A pipe has burst in your house. It's flooding your house. Yes, you can pump out the water, but you'd be better off going and stopping the flow of inbound water. Go turn off the water at the street. Epi stops the reaction. Epinephrine interrupts that chain reaction. Benadryl simply treats the symptoms. Another analogy I like to use is that of a house fire. If there is a fire in your bedroom, you can open the windows and put a fan in the window and blow the smoke out. That's Benadryl. That's antihistamine. Or you can go in with a hose and put out the fire. That's epinephrine. So epi is what fixes anaphylactic shock. There's nothing wrong with using Benadryl as an aid after you've already used the epi. Interventions, again, epi. Fluids are good for sepsis. And fluids are good for neurogenic shock. And then we may need to add vasoconstrictors, vasopressors, to the treatment for sepsis and neurogenic shock. And one of the better pressors for this is called norepinephrine, or Levophed is the trade name. But norepinephrine. And so when do you use those? Well, we start with fluids. And at some point, you have to make a decision, are they fluid responsive, or am I going to also need some norepi, some vasopressor for this? So generally, fill up the container, then you try to shrink it down. In the case of anaphylaxis, we want to interrupt the chain, fix the problem. If we had something quick to fix the systemic infection of sepsis, we'd go to that, but we don't have something quick. If we had a quick way to fix the problem in neurogenic shock, we'd go to that, but we don't. For anaphylaxis, we have a quick way to fix the problem, epinephrine. We go with that. Now, it is also true that the epi also works on some of the symptoms. Yes, epi and anaphylaxis also causes some vasoconstriction. It also dilates some bronchioles. So we get some side effects, some side benefit. Side benefit's probably a better term. We get some additional benefit, but the reason we're given the epi and anaphylaxis is to stop the chain reaction. If we had a way to stop the problem with sepsis, we'd do it. Had a way to stop the problem with neuroshock, we'd do it. In the meantime, we have to fill them up and then attempt to shrink it down. So Lab E is going to be kind of a wrap-up of all these types of shock. We've talked obstructive shock, where we had discussion about tension pneumothorax and cardiac tamponade and pulmonary embolus. We've talked about hypovolemic shock, whether it came from bleeding or whether it came from volume loss due to vomiting, diarrhea, sweating. We've talked about cardiogenic shock, whether that was because of a bradycardia or an extreme tachycardia, or some usually caused by a rhythm disturbance, or maybe an overactive parasympathetic nervous system. We've talked about cardiogenic shock in terms of stroke volume, whether they've simply lost too much left ventricular mass due to one or more myocardial infarctions, or they have a temporarily depressed pumping function. Remember, sepsis can do that. And so do we need to control the rate, or do we need to supplement the stroke volume, either with an inotrope or with preload increasing? And then we talked about distributive shock in terms of too little afterload, an excessively large container. And our plan there with at least anaphylaxis is stop the problem with epi. With sepsis and neuroshock, it's start transporting them to help deal with the problem. Those are longer term fixes. In the meantime, we fill up the container, and at some point we decide if that is not working, we're going to add to it with a way to shrink the container pharmacologically. So a lot of good concepts here. We redid this entire EMS 150 course to focus on shock, focus on these types of shock, assessment, and interventions. And so Lab E will be kind of a roundup and wrap up and review of all that sort of stuff. So we'll see you in Lab E.